Welcome, Dr. Pardiano, to this new episode of Eyesight Academy. It's a pleasure. I really appreciate that you accept my invitation to be with me today. I know that you have a lot of work and that you're a very busy person. We are very far away. You're in Indonesia, right?
Yeah, I'm so honored. Thank you
Yeah,
for
yeah,
the
yeah.
opportunity.
No, thank you. Thank you for your humbleness and your disposition for being here. I want to discuss something that it's quite interesting. It's kind of been taken in the in the black spot of the ophthalmology. Normally, we don't do it. And as I did my residency, it's like a complete no whenever we want to do a simultaneous bilateral cataract surgery. But I suppose that they can be some scenarios or some situations where you can benefit from that as long as you take the safety and all the necessary measures to do it correctly. So I have a few questions because honestly, I don't have experience about this, but I have seen some of your publications about this. And even I saw a more recent article that you published about simultaneous bilateral cataract surgery in tropical environment with all these kind of issues, right? With the hot and all that stuff. Let me just start asking you a few questions. From your perspective, what are the most essential safety principles that must be in place before considering immediate sequential bilateral cataract surgery?
Yeah, there are several questions for the situation. The first question is, does it really have to be bilateral? Often our patient come from far away, far off region, from outside of province, arriving with trust in their doctors. You know, Indonesia is a very fast country. Many are in a manner of speaking by perforce to have bilateral because the distance of the hospital from their home. However, there are still several questions that need to be confirmed here. Second question is, are there no contraindication of it? Is this the patient truly safe without diseases like diabetes mellitus that could react negatively to the phaco? And that third question, does the patient have enough time in our city before returning to their region? Is there sufficient support at home regarding the hygiene, sanitation, and so on to prevent post-operative infection, considering Indonesia's tropical conditions? So this safety factor is everything. We do not perform ISBCS or immediate sequential bilateral cataract surgery if there are no strong indication or there are presence of contraindication or unsuitable condition.
So, for example, you consider to do simultaneous bilateral cataract surgery in a patient that only reached these safety measures that you mentioned before. Uh, for example, if you have a patient with some discapacity or some what I have seen in my fellowship only twice of these cases where we decided to do it, and I can share it with you if you agree. There was only these patients with a high risk for anesthesia and with very high dense cataracts they don't see in any of both eyes, and it was too risky to go back to the OR to perform the second cataract surgery in the other eye. So, how is your approach in these circumstances? How is your approach when you decide to operate both eyes? You use the same OR route. You wait a few hours before proceeding to the next surgery, or it's exactly in the same OR, exactly in the same time.
Yeah, I didn't operate it, the patient with complicated condition for heart cataract, for example. I just choose the easy patient with normal cataract case with no complication.
Okay. So no hard cataracts, no other issues in the eye.
Yes.
That's one of the conditions. But for example, you operate, let's suppose that you choose a patient that is candidate for this approach. You operate one eye first, You immediately operate the other eye. You wait a few hours, a few minutes. You change all the all the prep and rep, like all the material in each eye. How do you do it in your practice when you have to perform it?
Yeah, for the patient who are for forced to have bilateral surgery and meet the requirements, we prepare two sets of sterile in while we change gloves, everything. The assisting nurse covers the eye that has just been operated on, and the assistant nurse disinfect the next eye simultaneously.
Okay.
Of course, decision is made if the phaco on the first eye went smoothly without issues, and the patient did not experience pain or anxiety. Each patient is asked about their condition. Yes, there are two or three patients who change their mind and decide to have one eye operated on for now, and that's not a problem because for me personally, unilateral surgery is still more advisable. I ensure all conditions are safe so that the second eye surgery is not negatively affected by what happened during the first eye surgery.
The most common misconceptions or misunderstandings of that surgeons can have about the risk of immediate bilateral surgery, especially regarding ophthalmitis. What do you think about this? Is this really an elevated risk when you operate both eyes in the same time, or no? What is your experience about this?
Yeah, actually, it's not a 100% misconception, I think. In fact, I'm among the doctors who are against ISBCS in the sense that ISBCS itself is not something that can just be done carelessly, especially, in Indonesia, which is humid, hot, and full of conditions that support bacterial growth. Yes, endophthalmitis is something that must be avoided. Come with me, no matter what. For unilateral surgery, awareness of this must be very high. So even more for bilateral standards must be applied in detail to prevent undesirable event. That is for both unilateral and bilateral surgery. Even have to pray before surgery for the safety for this reason. Endophthalmitis is mandatory.
Yes, of course, even with one eye, as you mentioned.
Yeah, avoid it. Even
Yeah,
more so for bilateral surgery, like that,
yeah, of course.
David. Yeah.
How do you ensure the complete separation between the first and the second eye, both in terms of instrumentation and decision making?
As I mentioned before, there are patient who is by perforce have bilateral surgery, but from beginning I know their condition is quite difficult. Then I consult this with fellow surgeon who practice with me to decide what needs to be done to ensure the safety of the patient, safety of the doctors, and safety of the hospital. I adhere to the principle that ISBCS should not proceed if the first eye encounters complication during phacoemulsification. I'm very grateful and thankful to God that so far my bilateral surgery have been without complication. And as I mentioned before, there are patients who request a delay immediately after the first surgery is performed. Uh, no problem, because unilateral surgery is fundamentally more recommended.
And what is your antibiotic strategy when you decide to operate both eyes? You use only topical, intracameral, you use systemic for reducing postoperative infection, and why? Or you prefer also to give a few days before the surgery topical drops of antibiotics also? What is your approach in this sense?
Sequentially, before surgery, I give 2 drops of levofloxacin, and for intracameral use, my good friend Steve Arsinov actually recommend movifloxacin, but since 2014, more than 11 years, I've been applying levofloxacin intracameral. We have ever published it in a journal, few thousand cases in journal. purpose of I give my patient levofloxacin every 3 hours for 1 week. Actually, 1 week should be sufficient, but considering the humidity and temperature, in Indonesia, I honestly become a bit paranoid because of it. So I give 1 more week by levofloxacin every 6 hours. The reason why levofloxacin has a broad spectrum, low resistance, lens penetration into anterior chamber, and is effective in preventing bacterial growth.
Yes, of course. Nice. And for example, what factors make you decide to, in your experience, how do you maintain the surgical consistency and focus when operated on two eyes back to back? Are there specific habits or mindsets that can help to decide? Like, for example, today I'm going to operate this patient and the plan is to operate both eyes. So, do you have a different mindset? Do you feel different before starting this kind of surgeries? Although it's just a cataract surgery, but it's in two eyes, do you feel different about this? Is anything changing in your mindset when you decide to operate both eyes?
Yeah. Sometimes in Indonesia, if you do charity, we should operate more than 80 eyes a day. Maybe our friends from Nepal, from India do more, maybe more than 100 a day. Each doctor. Regarding this situation, number one, I pray. Second, so that I always stay focused and know what I'm doing and what I am about to do. I maintain awareness. I have to make myself conscious and aware in entire process of surgery. And above all, I always ensure that unilateral surgery in all aspect is not inferior to bilateral surgery, so that I always maintain the same high performance and high attitude during both unilateral and bilateral. Both need exactly the same high standard to maintain.
Okay. So just to summarize a little bit about your approach and your decision to operate the patient with bilateral sequential cataract surgery immediately. For example, you choose a patient that is in general healthy, right, with no
Yeah,
comorbidities, no
correct.
diabetes, no other general or systemic issues that can cause any complications. You choose a patient that, in general, a confident patient that knows that he or she will underwent a bilateral cataract surgery and that there are no other significant issues in the eye. For example, you choose a patient that dilates well, that doesn't really has a very dense cataract, so you can avoid like several complications, right, during the surgery.
That's correct.
Okay, okay, interesting. What is your preferred technique for doing cataract surgery, by the way? You do pre-chop, stop and chop, divide and conquer.
I do chop technique from Nagahara.
Nice. Maybe you can send me one of your videos if you agree, and we can share your technique for cataract surgery in the channel also, if you like. I think it will be amazing.
Okay, I will send you one video.
Yeah. So I will proceed because I know that you have a lot of work to do. What is your learn curve, or what have you learned from high volume environments in Indonesia, especially about managing postoperative risk while still offering efficient care? Have you still participating in campaigns like when you operate like for charity, for example, 80, 100 cataract surgeries per day? How often you do this, or you prefer to be more relaxed and just operate a few cases a week?
In Indonesia, serve mass insurance performed and provided by the country. We have we have operated in my hospital alone 4,000 eyes in a year. So we must perform minimum 20 patient a day. Then maybe in few weeks, maybe in December 13, we have an assignment for operate 80 patient for charity. But not just me. Not, some doctors participate at that charity event.
Great. Yeah, but it's a lot. Still, it's been a lot. It's very tired when you operate a high volume cat.
Yeah.
I just have a few more questions for you, Doctor. Thank you very much for your time. I would like to, if you can share with us in your journey as a surgeon, what has been the biggest lesson, technical or personal, that has influenced the way you practice today? Is it has been a case, a significant or relevant case in your career that shape the way you see things, the way that you approach each patient? You have been like this localized and so with this order mindset all your time.
Actually, about the attitude of the operation from medical school. The principle of caution, fidelity to service standard, including surgical and post-operative care, compassion, attention, fulfilling patient need, caring for the patient, and helping them to solve the problem and striving our best to achieve their expectation uh, are things that our teachers have taught us and that we teach to the student in medical school across Indonesia. During the immense complexity of healthcare service in a country with the fifth largest population in the world and a super multi-ethnic society, this is a challenging situation in Indonesia.
What message would you give to a young cataract surgeons who want to adopt this technique, like immediate bilateral surgery, while keeping patient safety as their top priority? What is your advice to these young surgeons maybe that want to try this technique or this approach in some of their patients?
Um, that ISBCS offers many benefits in terms of patient comfort, time, and the hassle of follow-up controls. But if not performed correctly, the story will be quite different. Trust me. This reason, patient selection is extremely important for me. A strong indication, absence of contraindication are mandatory, and requirement fulfillment must be aligned in a supportive position. Standards, aseptic standards, infection, sterilization, and antibiotic use must be proper here. Surgeon's surgical skill must be truly considered. You know, you need to learn well with guidance and mentorship before becoming independent. Not just independent for the sake of it, but safely independence. Remember, ISBCS is not for every patient, not for every doctor, not for every hospital. In this regard, we all need to increase our awareness, caution, and not forget to pray. And for your information, a number of ISBCS is way far below our unilateral surgery. So unilateral surgery is more preferable to me.
I think it will be preferable to many.
Yes.
Honestly, I just wanted to touch this topic because I think it's important, Dr. Pardianto, the things that you're sharing with me today, and I hope with the people that will watching us. There are some issues I have seen in my practice, some situations where they decide to operate both eyes with not a real indication or not with a real need to do it for the patient. As you mentioned, the patient goes first, right? The safety of the patient goes first. And I think that I always tell this to my colleagues, some young residents, and even to myself and to my patients. Everything goes well with the patient everything goes well with me, with the surgical team, with all the environment surrounding the patient. If everything goes wrong with the patient, everything goes wrong around the patient. It's not just one patient and that's it, or one eye and that's it. It's all the environment that surrounds the patient when we are working on. I have seen some situations where doctors just decide to operate both eyes at the same time. In terms of economically, you know what I mean? Not for the benefit of the patient, but for an economic. Seen some situations where I just would like to tell them like, no, please stop, don't do this in this patient. I think it's not the best idea. They usually don't take the measures that I have seen some situations where they don't even take the real measures for one eye
Yeah.
for one single operation. If you do something wrong for one eye, they will copy and paste for the second eye. So it's not convenient for both eyes. And outcome or a situation in both eyes is catastrophic. Even for one eye, it can be catastrophic. So the main objective for what I decided to talk this with you, and that you share your experience and your humbleness and your willingness to say that yes, you can operate both eyes, but you need to be aware of the situation, that is not for every patient, not for every doctor. You need to very choose wisely the patient for the situation. So we can create some kind of consciousness about this. It's not like it's not smoothly to say I will operate two eyes instead of one and then wait a few weeks and then operate the second eye. I think that in my experience, I don't feel comfortable yet to decide to operate both eyes in the same day for a patient. I do believe, because I have seen it in my fellowship, for example, where the patient can benefit a lot from this approach while you are following these safety measures and these safety steps. That's what I wanted to talk about this, not because to put it in the map like the hey, we should start operating both eyes simultaneously, everyone. No, 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 no. It's not to invite the people to operate simultaneously. It's just to some people do already, some people have done in the past. So maybe they can learn from your experience, and maybe the people who is thinking, hey, I'm going to start operating both eyes simultaneously, to maybe stop, wait a few minutes and realize if it will be the best choice for the patient. Finally, the last question, Dr. Pardianto, do you hope your legacy will be for the next generation of Indonesian ophthalmologists, especially in terms of safety and patient care? What you would like to be your legacy in Indonesia for your work, for what you're doing today? I always ask this kind of question sometimes, because for me, every surgeon, every ophthalmologist that I have the privilege to talk in this section, in this podcast, I want to learn from you, not just from your experience, not just from your experience in ophthalmology, but for your from your experience in life. Because the way that you conduct, or you have been conducted your life through all these years, it has reached the point where you are now, and it's admirable. An admirable professor, you're an admirable ophthalmologist in Indonesia. Aspire a little bit to be in some of that positions. I always ask your experience in life too, and your advices in life, and what you would like in your legacies. I know that it can be more personal, but it's something that can inspire me and can inspire some other young ophthalmologists.
Yeah, I have learned from Dr. Professor Alan Crandall from late Professor Alan Crandall from Utah, America. He was a good surgeon, good performer, good speaker, good writer, good teacher, and good surgeon. And, he achieved 5 humanitarian awards, not just award, but he gave his attention to humanity very well. I learned much from him, actually. I have tried to wrote a book to some journal manuscript, teach in medical school, in so many scientific forums, just to share my knowledge and my attitude and my uh, awareness for others, and then I hope it be it can be of great benefit for others. Hopefully, this will be useful for all of us to improve our service, our contribution to humanity, and make our one life can be more meaningful.
Yes, of course, meaningful for everyone and for us. Dr. Pardianto, I really admire your humbleness and your willingness to talk with me today. I don't want to take more of your time. I know you have a lot of things to do. You wrote me in the email that you review manuscripts, you write articles, you make lessons in your residency program, right? A lot of work to do. I know that that takes a lot of time. So for you giving me this small amount of your time, it's a huge value for me. So thank you very. I really appreciate.
Thank you so much, David, for your kindness and opportunity you give to me too. I am very honored and very happy.
Me too. Me too. Thank you very much. I hope to visit you soon in Indonesia. I have never been there, but
Oh yeah,
I promise
thank you so much.
I will make my plans to visit you soon. And why not? You mentioned something about writing a book, right? So I am willing to write also something maybe as part of my legacy.
Oh,
It will be amazing that you can contribute and we can do something together
thank
sooner
you
than
so much.
later. It would be
Thank
amazing maybe to
yeah,
write something together, some start for some article maybe at the beginning, but if we can write something in a book or something that can be printed on and stay for the after we passed away of this life,
yeah.
I think that will be great.
Thank you so much, David. Check to our my email. Yeah, my email. Maybe in the bottom of my email, usually there is a link of our books. One of our book published by Springer last year.
Okay, great. Yes, I will.
Work, yeah, work from 49 doctors from 17 countries across the world.
Wow, wow. So let's write another one. Let's do
Yes,
another one.
right now we are in a project of intraocular power calculation. It will be published by Springer too.
Great, great. I'm eager to see it. Thank you very.
Thank you so much,
Thank
David.
you, Doctor. My pleasure to be here with you today.